Welcome to the Internal Medicine Wing. Today, we are discussing the most common and arguably the most frustrating cause of severe liver disease in cats: feline hepatic lipidosis, often called fatty liver disease. What is it? It is exactly what it sounds like. It is a massive pathological accumulation of triglycerides inside the liver cells, called hepatocytes. The mechanism. The liver is designed to process fat, but in feline hepatic lipidosis, it gets overwhelmed. The cells swell with fat, physically crushing the biliary channels. The result. This leads to severe cholestasis, meaning bile can't flow, hepatocellular dysfunction, and eventually, total liver failure. The stakes. Historically, this was a death sentence, but today, the narrative has flipped. The danger. Without treatment, it is fatal. The hope. With aggressive early enteral nutrition, survival rates now exceed 80 to 90%. The mantra. In this disease, food is not just supportive care. Food is the medicine.
Pathophysiology, the metabolic traffic jam. How does a cat starve itself into a fatty liver? It seems counterintuitive. To understand FHL, you have to understand the cat's unique, obligate carnivore metabolism. The trigger: negative energy balance. It starts when the cat stops eating. The mobilization: the body panics and thinks, "I need fuel." It triggers a massive release of fat from the body's peripheral reserves. The flood: these free fatty acids, or FFAs, flood into the liver at a rate the liver cannot handle. The bottleneck: the VLDL failure. Here is the fatal flaw in feline biology. The job: the liver is supposed to repackage these fats into VLDL, or very low-density lipoproteins, and ship them back out to be used as energy. The failure: cats have a very limited ability to scale up this shipping process. The dock gets overwhelmed. The result: the fat has nowhere to go. It piles up inside the liver cells. The damage: intrahepatic cholestasis. This isn't just about storage space. The squeeze: as the hepatocytes swell with fat, they physically push against each other. The blockage: this swelling collapses the tiny bile canaliculi running between the cells. Bile can no longer flow. It backs up into the bloodstream, turning the cat yellow, or icteric. Why cats? Why doesn't this happen to dogs? Because cats are obligate carnivores. They have high baseline protein requirements and cannot downregulate their protein turnover quickly. The timeline: it happens fast. In an overweight cat, just 3 to 5 days of anorexia is enough to initiate liver failure.
Etiology, the domino effect. We know how it happens, the starvation, but why did the cat stop eating in the first place? We divide cases into 2 buckets: primary and secondary. Primary lipidosis is idiopathic, meaning there is no physical disease starting the fire. It is purely psychological or environmental: stress, obesity. However, in the majority of cases, lipidosis is secondary. The cat has an underlying illness that causes nausea or pain, leading to anorexia. Here is the golden rule: always assume FHL is secondary until proven otherwise. Triaditis, metabolic, pain. If you place a feeding tube but miss the pancreatitis or the rotten tooth, the cat will not recover. You are treating the symptom, the fatty liver, not the disease.
The signalment. The classic patient is a middle-aged, overweight cat that has recently stopped eating after a stressful event or illness. Clinical signs. When you examine them, the signs are glaring. Icterus, the hallmark. These cats are yellow. Check the sclera, the gums, and the pinny, ears. The bilirubin is backing up because the bile ducts are crushed. The muscle wasting. This is a crucial finding. The cat might still have a primordial pouch of belly fat, but touch their head and spine. You will feel severe temporal and epaxial muscle wasting. The body is cannibalizing its own muscle for protein. Twilism, drooling. Nausea is intense. They are often salivating profusely. The brain. In late stages, look for hepatic encephalopathy dullness, stargazing, or seizures.
Physical examination, the hands-on assessment. When you put your hands on this patient, you are confirming the severity of the metabolic crash. First, hepatomegaly, the swollen liver. While not always palpable in obese cats, you will often feel a smooth, enlarged liver extending beyond the costal arch. This helps differentiate it from chronic cirrhosis or portosystemic shunts, where the liver is often small and shrunken. Second, jaundice or icterus. We mentioned this before, but it bears repeating. It is usually generalized. Check the sclera, the pinnae or inner ears, and the oral mucosa. If they are yellow, the bilirubin is sky high. Third, the vital signs, dehydration and temperature. These cats are often severely dehydrated with tacky gums and prolonged skin tent because they haven't drunk water in days. Hypothermia is a critical prognostic indicator. If the cat is hypothermic, they are in shock or metabolic failure. You cannot start feeding a cold cat. You must warm them up first, or they won't digest anything. Fourth, weakness and ataxia. Look for profound weakness. If the head is hanging low, check their potassium. Hypokalemia causes neck weakness. If they are stumbling, suspect hepatic encephalopathy or ammonia toxicity.
Patterns in the blood. You suspect it, but the blood work confirms it. FHL has a very specific biochemical fingerprint. The enzyme gap, ALP versus ALT. The signature. Look at the ALP, alkaline phosphatase. In FHL, it is often massively elevated, frequently higher than the ALT. The difference. Remember, dogs get high ALP from stress or steroids. Cats do not. If a cat has high ALP, it is purely cholestatic disease. It is a screaming red flag for lipidosis. The electrolytes, the danger zone. Hypokalemia. Low potassium is common and contributes to that weakness and neck ventriflexion. Hypophosphatemia. Watch this closely. It is often low on admission, but it will crash even harder once you start feeding, refeeding syndrome. If the cat is already hyperbilirubinemic, no need to run bile acids.
Blood work gives us the clue, but imaging and sampling give us the verdict. Abdominal ultrasound, the bright liver. When the probe hits the abdomen, the liver lights up. The look. We see a diffusely hyperechoic or bright white liver compared to the kidney. The fat reflects the sound waves. The shape. The margins are rounded and swollen. The liver is literally bursting with fat. The caveat. Ultrasound is supportive, but not perfect. It can easily miss the underlying pancreatitis or cholangitis hiding in the background. Cytology, the gold standard. To be 100% sure, we need cells. The method. An ultrasound-guided FNA, or fine needle aspirate, is usually sufficient and much safer than a core biopsy in a cat with clotting issues. The finding. Under the microscope, you will see hepatocytes packed with lipid vacuoles. The cytoplasm is completely displaced by fat. The ICU rule. Here is the most important takeaway. Do not let the perfect be the enemy of the good. If the cat is unstable, yellow, and fits the profile, start treating. Do not delay nutrition while waiting 3 days for a pathology report. You can confirm it later. You have to save them now.
Nutritional support. Food is the medicine. Let's be clear, you cannot drug a cat out of lipidosis. You have to feed them out of it. There is no effective treatment without aggressive nutrition. The root, the E-tube, the MVP. Forget force feeding, it creates food aversion. You need a tube. The gold standard, the esophagostomy tube or E-tube. Why? It is quick to place, well tolerated, and crucial for discharge. Owners can use it at home for weeks. The alternative, Use a nasoesophageal or NE tube only for the first 24 hours if they are too unstable for anesthesia, but get the E tube in as soon as possible. The trap: appetite stimulants. The warning: do not just give mirtazapine or entice and hope they eat. It delays definitive treatment. These cats are nauseous. They need calories guaranteed, not encouraged. The strategy: start low, go slow. We do not fill the tank on day 1. The risk: refeeding syndrome. If you flood a starved body with carbs, insulin spikes, and it drives phosphorus and potassium into cells, causing fatal hemolysis and weakness. The protocol: start at 25 to 33% of RER, or resting energy requirement. Increase slowly over 3 to 5 days to reach 100%. The menu: busting the protein myth. The myth: liver failure means low protein. False. The reality: unless they are seizing from hepatic encephalopathy, these cats need high protein. They need amino acids to build the lipoproteins, or VLDL, required to ship the fat out of the liver. Restricting protein actually prolongs the disease.
Medical management has 3 priorities: electrolytes, vitamins, and hepatoprotectants. Hydration. Start with balanced crystalloids to fix the dehydration. You cannot clear the bilirubin if the kidneys aren't perfused. Must monitor potassium, phosphorus, and magnesium. Check electrolytes daily for the first 3 days. Supplement aggressive potassium and phos in the fluids if needed. Almost all FHL cats are B12, cobalamin, and thiamine deficient. Add a B complex to the fluids. This improves appetite and metabolic function. The liver makes clotting factors. If you see bruising or suspect coagulopathy, start vitamin K1 injections immediately. Hepatoprotectants. Give SAMI and Silibin, milk thistle. Ursodeoxycholic acid is great for thinning the bile, but contraindicated in bile duct obstruction.
You can put food in the tube, but if the cat vomits it right back up, you are losing the battle. We need to shut down the nausea pathways hard. We often use a multimodal approach because nausea hits from different angles. Mirapetant, or Cerenia, is your baseline. It blocks the vomiting center in the brain at the NK1 receptor. Ondansetron, or Zofran, is the heavy lifter for severe nausea. It blocks the signals coming directly from the angry gut at the 5-HT3 receptor. The strategy is to use them together. They work better as a team. Now, about the mirtazapine rule. Do not use mirtazapine as your primary treatment. It is an appetite stimulant, not a cure for liver failure. Use it only after you have established feeding and hydration. It helps with the transition back to oral eating, but it cannot replace the tube in the acute phase. You can put food in the tube, but if the cat vomits it right back up, you are losing the battle. We need to shut down the nausea pathways hard. We often use a multimodal approach because nausea hits from different angles. Mirapetant, or Cerenia, is your baseline. It blocks the vomiting center in the brain at the NK1 receptor. Ondansetron, or Zofran, is the heavy lifter for severe nausea. It blocks the signals coming directly from the angry gut at the 5-HT3 receptor. The strategy is to use them together. They work better as a team. Do not use mirtazapine as your primary treatment. It is an appetite stimulant, not a cure for liver failure. Use it only after you have established feeding and hydration. It helps with the transition back to oral eating, but it cannot replace the tube in the acute phase. In severe cases, the liver stops processing ammonia and the brain gets poisoned. The cat gets dull, has head presses, or drools excessively. We give lactulose orally. It changes the gut pH and traps ammonia, converting it to ammonium, so it gets pooped out instead of absorbed. We use metronidazole or amoxicillin to kill the gut bacteria that produce the ammonia. Be very careful with metronidazole doses in liver cats. The failing liver cannot metabolize it, and it can cause neurotoxicity itself. Go low dose. Only restrict protein if the HE signs are severe, such as seizures or coma. Once the mental status clears, get them back on high protein immediately. The liver needs those amino acids to repair itself.
Once the tube is in and the fluids are running, the marathon begins. You need to know what to watch to ensure you are winning. The daily watch list. Body weight. Check this daily. If they are losing weight, bump the calories. If they gain too fast, it's fluid retention. Electrolytes, especially phosphorus. Keep watching it for the first week. If it drops, the red cells pop. Feeding tolerance. Are they keeping the food down? If not, adjust your antiemetics or the feeding rate. The weekly trends. Bilirubin. This is your scoreboard. It should start dropping within days. Liver enzymes, ALP and ALT. Don't check these daily. They lag behind clinical improvement. Check them weekly. They might stay high for weeks even as the cat gets better. That is normal. Prognosis. The good news. If you act fast, the odds are excellent. The stat. With early, aggressive nutritional support through eTube, the survival rate is 80 to 90%. The timeline. Warn the owners. This is not a 3-day fix. Full recovery usually takes 6 to 12 weeks. The tube stays in until the cat is eating 100% of its calories by mouth for a week. When do we fail? Prognosis drops if there is severe concurrent disease, like untreatable cancer or massive pancreatitis. Delayed feeding. If the cat starved for more than 10 days before you saw them, the liver damage might be irreversible. The owner factor. If the owner cannot manage the feeding tube at home, we often lose the battle.